Okay, so I want to talk a little bit about the role of physical therapy in the treatment of pelvic pain. And a little bit about myself is, first off, my name is Kristina Koch. I practice here in Colorado Springs. I graduated from Springfield College in Massachusetts. All right, East Coasters. And in 2001, I was introduced to the field of pelvic floor therapy. And my career took a drastic change from where I thought it was going. And I began taking courses and learning more about what exactly is involved in the treatment of this population. And then in 2013, I actually became a certified women's health therapist by the American Physical Therapy Association. And last year, I also did my lymphedema training, so I'm certified in the treatment of those patients as well. So as we heard earlier, I actually think I have the same exact quote here as Dr. Eckenberg. 20% of women will experience pelvic pain at some point in their lifetime. 10% of visits to the gynecologist are due to chronic pain, and almost 25% of women will still be experiencing pain 18 months postpartum with intercourse. 90 to 95% of all prostatitis cases are actually male pelvic pain. So it is much more common than we think about, has already been stated. People aren't talking about it, they're embarrassed about it. When asked, they do want to talk about it though. So the causes of pelvic pain. Lots of things can be causing pelvic pain. And a lot of times it's not just one thing that occurs during a lifetime, but it might be something that happens over months, years, or even decades. It might be something like you have a fall, slip on the ice. A year later, you're experiencing recurrent urinary tract infections. And then it's just a snowball effect. One thing is just compounding another. And our body can only take so much before it's going to fall apart, and there's going to be dysfunction. So some of the causes, like I just said, trauma, that can be falls, maybe sexual abuse, even motor vehicle accidents, childbirth, episiotomies, tears, use of forceps or suction, recurrent urinary tract infections, endometriosis, chronic prostatitis, the interstitial cystitis, and the painful bladder syndrome, nerve compression or damage. We'll talk a little bit more about some of the anatomy and some of the nerves that can become involved later on, constipation and IBS, pelvic congestion. A lot of times we will see this in some of the oncologic conditions. Poor posture. Years of sitting poorly is going to shorten the pelvic muscles, which then can potentially cause issues. Dermatologic conditions, lichen sclerosis, lichens planus, and then surgeries, any of the abdominal surgeries, hysterectomy, hernia repairs, gallbladders, appendectomies. So I'm going to cut to the chase. Why physical therapy? First, nearly every pelvic pain condition is going to have a neuromuscular joint or a fascial component. Physical therapists are neuromuscular and musculoskeletal experts. And lastly, we have the time. Aside from Dr. E, who gets 2 hours, which I'm a little jealous of, to take his histories, physical therapists typically are going to get 45 minutes to an hour, whereas some of your primary care doctors, the nurse practitioners, the PAs get 15 minutes to get a full history. And that's awfully hard for people who are dealing with persistent pelvic pain because their histories take a lot longer than 15 minutes. So for some, just review here, but the bony anatomy is going to consist of, oh, I forgot can you bring my, sorry, Sarah, I did bring my pelvis. I forgot it, I forgot my pelvis. And it is just the female, sorry, men, all right? And I will pass this around. So we've got the ilium on the sides, sacrum in the back, including the sacroiliac joints, pubic symphysis in front. Hip joints are attaching onto here, so we can't forget about that. And also the lumbar spine and the thoracic spine. And I include those because of the innervation from those levels into the pelvis. We also know that the diaphragm is very related to the pelvic floor. And those are fascially connected. Diaphragm up here, it does, I'm not going to go into all that because we could be here for days talking about anatomy. So the muscle layers of the pelvic floor. There are 3 layers of muscles: the urogenital triangle, the urogenital diaphragm, and the pelvic diaphragm. Okay, so going into a little bit more on that. And I'll just pass this little guy around. There you go. Thanks, Karen. Okay. So the urogenital triangle is our most superficial muscles, innervated by the pudendal nerve, which, again, we've been introduced to a little bit earlier today, and I'll talk a little bit more about that. But we have bulbospongiosis in males, the bulbocavernosus in the female here is kind of that equivalent. We've got the ischiocavernosus on either side, and then this muscle coming across is the transverse perineum. Our middle layer is called the urogenital diaphragm again, also innervated by the pudendal nerve. It's going to include the urethral sphincter and this deep transverse perineal, as well as the external anal sphincter. So those 2 layers can be affected during childbirth, so potentially episiotomy or just a natural tear. That's going to cause scar tissue. For most, that's fine, but there is going to be a population where potentially that scar is going to become painful, causing pain with intercourse and potentially other issues with pelvic pain. The deepest muscle, innervated by segments from off of the sacrum, S3 to S5, is going to include the levator ani, which is here, okay? The iliococcygeus, the coccygeus, our piriformis, and then the obturator internus, which is actually, well, piriformis and obturator internus are hip muscles. So a lot of times we will see people with chronic pelvic pain are having hip pain, or it started out as hip pain, and it is now becoming pelvic pain. So some of the muscular sources of pelvic pain. Just like anywhere else in the body, pelvic muscles can become short, tight, and weak. So trigger points or tender points, as they are now being referred to a little bit more. The theory of trigger points that was set out by some physicians many years ago by Travell and Simons is being challenged a little bit currently. What used to be a muscle knot, they potentially think might be irritated nerve endings. So there is a little bit of, I don't want to say controversy, but there could be some new research coming out in terms of how we're treating them. But as of now, they are hyperirritable areas in taut bands of muscle or connective tissue, which when palpated are tender, can refer pain, and also can cause motor and autonomic dysfunction. They can be characterized as active or latent. An active trigger point is one that is causing pain at the moment. That pain may also be referred. And a latent trigger point is there. You don't really know it's there until you press on it. Dr. Eckenberg earlier talked about Lorimer Moseley and David Butler, who are 2 physical therapists out of Australia. And they're talking a little bit more about, again, what these trigger points are, and maybe it's more of a centrally mediated response, meaning it's more of the central nervous system. And they've got some great information out there. Lorimer Moseley does a TED Talk that you can look at on YouTube. It's a 14-minute. It's fantastic. I encourage everybody to just take a moment to watch that video. His name is Lorimer, Lorimer, and the last name is Moseley, Moseley. And he really goes into explaining how the central nervous system is a part of this whole process with pain. So muscles that can refer pain to the pelvis: the abdominals, the rectus abdominis, and the obliques; the adductor magnus, which is on the inside of the leg, of the thigh; the levator ani and coccygeus in the pelvic floor; the obturator internus, as well as some of the small muscles in the back called the multifidi. So here we see rectus abdominis can refer to the lower abdomen, the groin, testicles, the bladder. Also can cause, when they're in the lower abdomen, potentially contributing to dysmenorrhea, urinary urgency, and frequency. The adductor magnus is going to be also referring to the pelvic floor, vagina, rectum, and the testicles. And levator ani and the coccygeus may cause symptoms or pain in the urethra, bladder, around the perineum and anus. There might be pain during or after ejaculation. May have a feeling of fullness in the prostate. Another one that can cause urgency and frequency, and a lot of times the person will say they feel like they have a golf ball in the rectum, causing lots of discomfort when sitting. The obturator internus is going to be referring out to the hip, the sacrum, back into the thigh. Also may cause some urethral and vulvar burning or pain. And then the multifidi are typically going to be referring just to the areas adjacent to where at the segment where the trigger point is located. It can also refer into the abdomen and the sacroiliac joint as well. So some of the neural sources of pain. Pudendal nerve, a lot of times, is brought up. And again, Dr. Google, you get on, and everybody's got pudendal neuralgia, and they're doomed. It's a dreaded diagnosis. It does have 3 branches going to various parts in the pelvis, and it is coming off of S2, S3, and S4. It's going to come down. It's going to go underneath 2 muscles in the pelvis, the piriformis and the coccygeus. It can get caught up there if those muscles are tight, cause irritation, and then you'll get pain along its distribution. It can also get caught up between 2 ligaments. Here we've got the sacrotuberous ligament and the sacrospinous ligament. It's coming right in between those. So any dysfunction that anybody might have at the sacroiliac joint potentially could be causing symptoms of pudendal neuralgia. The iliohypogastric nerve is a nerve that is coming off of the spine at the levels of T12 and L1, and it's going to provide input to the abdominals, the obliques, the skin of the what we call the back outside portion of the gluteal muscles, and the suprapubic region. This muscle goes through our psoas, which is a hip flexor muscle, as well as our obliques. So again, if you get tension in any of those areas, you could get pain along this area and into the pelvis. The ilioinguinal nerve is another nerve that is going to be going down into the groin and the pelvis as well. It's innervating the skin of the pubis, the upper thigh, the penis, and the anterior scrotum in males, and the labia majora in females. This too, passing through here, is going to come, it's coming through the psoas muscle, through the transverse abdominis and the internal obliques. The genitofemoral nerve, coming down here, it's got 2 branches. It's got a femoral branch, which is going to come this way, and a genital branch coming down here. Okay. It is going to innervate the scrotum in males and the pubis and labia majora in women. This too passing through the psoas, can become compressed there. Another area that these muscles can, or another reason these muscles can get irritated and compressed is after abdominal surgeries. Hysterectomies, hernia repairs, appendectomies can just cause some irritation around those nerves. And we think about our society now, and we do so much sitting at computers, sitting at work, and that is going to shorten our hip flexor muscles. So again, we've got two of these muscles going right through the hip flexor. That poor posture, that lack of movement can cause pain. Last nerve that I want to talk about is the posterior femoral cutaneous nerve. And this is coming from the sacrum. I'm not going to be able to reach it, but it's up on the outside there. It is traveling under the gluteus maximus muscle, and it's traveling very close to the sciatic nerve. And it's going to innervate the back of the thigh, the lower buttocks, and the posterior scrotum in men and the labia in women. So PT assessment. So I just wanted to go over some of the things that could cause pain from a neuromuscular standpoint. But our PT assessment, we're going to look at a lot of things. We're going to look at the alignment of the spine and the pelvis. Is there something off? Is the sacrum rotated? Are one of those hips, the ilium, is that rotated, maybe causing some changes or dysfunction in the muscles or the nerves? We're going to look at the low back, the pelvis, the pelvic muscles, the hip muscles, for any trigger points or tender points, areas of tension, or is the muscle short in any of those areas. We're going to look at the strength and motor control of the pelvic, abdominal, and hip muscles. Not only do those muscles have the ability to contract, but can they relax? What state are they in when they're just at rest? Are they shortened? We're going to do postural assessments. Again, if you sit down and you're slouched, you're shortening your pelvic floor. If you've had any of those other conditions, if you've got IC and the pelvic floor muscles are already tightened in response to the pain that you're feeling in the bladder, now you're shortening them even further. But of course, what position do you want to go into, because what feels best? You want to go into the fetal position. So now you're shortening your pelvic floor, and you're also shortening your abdominal muscles. So then they get tight. So we see all these other things that end up occurring as a result of the pain from the organ or whatever else might be going on. We're going to assess breathing patterns. When people are in pain, they take shallow breaths. One of the roles of the pelvic floor is to work as a pump with the diaphragm to pump out fluid. If you're not taking that deep breath in, then you're not actually stretching the pelvic muscles. They're not contracting and acting like that pump. We're going to look at the mobility of the viscera. So not all therapists have been trained in this particular area, but we can see, what's happening to the ligaments on the side of the bladder? Is something tight on one side? Is something loose on the other? And we actually can work to improve that. We're really using the connective tissue to assess the organs. I'm not going in and grabbing onto your bladder and shoving it in different directions. But what we're looking for is a symmetry. Is there tightness? Can we improve that so that the organs can slide and glide over one another like they should in normal function? So treatment may include connective tissue massage, myofascial release, visceral manipulation techniques in order to normalize that soft tissue and that connective tissue. Might include intramuscular therapy or trigger point dry needling. I've seen some great success with the trigger point dry needling, and now I'm realizing as I'm doing some more research into the neuroscience of pain that maybe we're not necessarily treating the muscle when we're doing that, but we're treating the nervous system input to that area, which is improving what's happening at that muscle. We're going to potentially do some joint mobilizations, muscle energy techniques if we're finding that there are alignment issues in the pelvis or the spine. Again, visceral manipulation techniques in order to improve the ability of the organs to move on one another and in their space. Neuromuscular re-education to improve the motor control of the core muscles, the pelvic muscles, and the hip muscles. Again, can they contract? Can they relax? Can they lengthen like they should when we're having a bowel movement or when we need to void? Postural education, again, correcting breathing. And at the very end, I'm going to give you all a little take-home, a little breathing technique to calm down the nervous system for some what we call physiological quieting. Doing a lot of pain education, again, using Lorimer Moseley and David Butler, kind of on the forefront right now of this new pain science. We may use ultrasound or electrical stimulation in order to manage that pain. And of course, we're doing self-care and home exercise programs for people. It's just as important that when you come and when you're leaving, that you feel like you have some tools that you can take with you to manage at home. So my conclusion, physical therapy really should be a part of of all cases of pelvic pain with the interdisciplinary team. We have the time and the expertise to look at the neuromuscular or musculoskeletal aspects that are going to either be driving or a result of the pelvic pain that a person may be experiencing. And this has been touched on before. Pelvic pain is not something that people want to talk about. They're embarrassed by it. They're ashamed. There's a stigma around it. So it is so important to bring these things up during the visits. I remember, this isn't necessarily related to pelvic pain, but it was the first time anybody had even asked anything about my pelvic floor, was I went to, I just had my physical. And the PA said, "Are you having any issues with your bowel or bladder?" And I said, "Thank you." "No, I'm not, fortunately. I'm very lucky. But thank you for asking me, because it's the first time I've ever been asked that question." You know, and she's like, "Really?" And I said, "Yes." So again, you know, that's another area where people don't want to talk about it, but so much more so with pain. So before I finish up, I do want to send everybody home with a little activity that's going to help to quiet the nervous system. So this is great if you're having a flare, if you're having anxiety, if you're having insomnia. So it's something called 4-7-8 breathing. So I want everybody to get their feet on the floor, both feet, okay? Don't start it yet. So what you're going to do is you're going to inhale for a 4 count. This isn't necessarily 4 seconds, it's just a 4 count. And then you're going to hold that breath for a 7 count. And then you're going to exhale for an 8 count. Inhaling through the nose, allowing the belly to expand as you do this, and then exhaling through the mouth. So I'm going to count you through. So go ahead and inhale, 2, 3, 4, hold, 2, 3, 4, 5, 6, 7, exhale, 2, 3, 4, 5, 6, 7, 8. Inhale, 2, 3, 4. Hold, 2, 3, 4, 5, 6, 7. Exhale, 2, 3, 4, 5, 6, 7, 8. One more. Inhale, 2, 3, 4. Hold, 2, 3, 4, 5, 6, 7. Exhale, 2, 3, 4, 5, 6, 7, 8. Everybody should feel much more relaxed now. So that's just it's a really nice exercise to do. You can do it anywhere. So a little take home for you.